Hi, everybody. Today, I'd like to talk to you about the functional medicine approach to depression and anxiety. As you know, the DSM-4 was supplanted by the DSM-5, and that rearranged the categories within which we classify mental health problems, including mood disorders. But the most important point here is not really how we're classifying these things. The most important thing is that this classification has nothing at all to do with the etiology or cause of mood disorders, and is really a document that is useful to some degree for research and really mostly for insurance companies. The DSM-5 mood disorders include unipolar depression, seasonal mood disorders or seasonal affective disorders, bipolar depression, type 1 and type 2. Type 2 is milder than type 1, and genetically that seems to be sorting with the unipolar depression, where you just have the down moods. And then there's cyclothymic disorder, which is a milder form of this cycling. And then we have persistent depressive disorder, which used to be thought of as a dysthymic disorder, and then PMS and disruptive mood regulation. Then we have anxiety disorders, which we're going to talk about as well. And that has many, many things in that category, including separation anxiety, selective mutism, specific phobia, social phobia, agoraphobia, generalized anxiety disorder, etc., OCD, and body dysmorphic disorder, hoarding, etc. What we know now is that really these categories are not really useful, because the categories don't really reflect the etiology or source of the problem. So, for example, if we looked at a QEEG brain map, looking at the different networks in the brain, we would see that these disorders have many overlapping parts of the brain. So it's really much more useful to look at brain networks and look at those and determine, okay, what are the symptoms that come out of these network dysfunctions? And the symptoms can vary, but it's the DSM-5 is not particularly useful. What we know is that depression and anxiety actually are heterogeneous. So, for example, the sources or the causes of depression can be from anything from a combination, usually, of digestive problems. The gut-brain axis can be dysfunctional. We have chronic inflammation or chronic infections. We could have hormonal problems. We can have family stresses, societal stresses, right? COVID, the pandemic, and the changes that that has brought upon us, sleep disruption, um, uh, family history, genetic vulnerabilities, methylation problems, many, many factors. So that really what you need to do is take a systems biology approach and really abandon the idea that there's a magic bullet. I like to tell a little story. Um, when I was in practice for maybe 10 years, I had a woman who came into me with depression, and I said, well, I'll give her some imipramine. It's an antidepressant. It was commonly used. Weeks later, she's feeling great, and I was really feeling good. I was pretty sure it was the imipramine, but I didn't tell her that, and I asked her what she attributed the improvement to, and she told me that her mother-in-law had moved out. Well, I was like, that was the end of my trying to figure out what is making people better, and the best approach is to identify the problems in the different systems that we know are affecting people or can affect people by doing laboratory testing, taking a careful history and physical, and treat the things that are abnormal and get them normalized, and then people will actually do better. So, question is, how effective is the current model in the treatment of mood disorders and anxiety disorders? And the shorter answer is not really so effective. The standard model right now is psychological therapies. So, for example, cognitive behavioral therapy plus pharmacotherapy or combination of the two. But the efficacy is not really so good. And then, of course, we have side effects, et cetera. In mood disorders, anxiety disorders, exercise is an excellent adjunct. There are some other things that people are exploring, like hypnosis, autogenic training, biofeedback, complementary medicine methods like acupuncture, osteopathy, homeopathy, I should say. But the evidence for these things in terms of, for example, hypnosis is not really very good. So the current treatment, being psychopharmacology and medication, was subject to a trial. It's called the STAR-D trial, which is in the early 2000s. And basically what they tried to do is replicate the real world functioning of psychiatrists treating depression. And so what they did is they put people on a medication. They offered them psychotherapy. If a medication didn't work, then they might add a second medication, or offer to change the medication to a different medication that had a different mechanism of action. And they really put about 4,000 people through this. And what they found was there was a 50% response, meaning some kind of improvement to the standard treatment. But 50% of the responders relapsed within a year. And the long-term remission rate, meaning a 50% reduction in the amount of depression, was 25%. And the full recovery rate, meaning no depression, that full recovery rate was even lower. So the prevailing model of psychotherapy and medication is failing. There's no other way to say it. This was actually acknowledged by Tom Insel, who was the formerly the director of the National Institute of Mental Health, and he said in, I think, 2015, that the bottom line is that these medications, antidepressants, appear to have relatively small effect in patients classified as having depression. And at a biological level, and really he didn't say this, but at a psychosocial spiritual level, depression comprises scores, quote, scores of different disorders. So we know that depression and anxiety is a heterogeneous, it's a syndrome. It's kind of like you have pneumonia, right? Pneumonia, but you don't know what kind of pneumonia it is. Is it pneumococcal? Is it tuberculosis? Is it mycoplasma? Is the person an alcoholic? Then it made them more vulnerable to the pneumonia, et cetera. So depression is a syndrome, a collection of symptoms. Anxiety, a collection of symptoms. But what's underneath that common symptomatic picture? Well, there are many different things. And so that I'd like to talk with you about that. Some of the common things that we think contribute are, and this is a big one, I believe, because depression, for example, and anxiety, but particularly depression, is actually the largest cause of disability in the world now. That's depression, the largest cause of disability in the world. So why? And in my opinion, a big part of it, it's not the only reason, a big part of it is the disruption of the social fabric. There's a breakdown in the family. There's a big breakdown in community. We see it all around us now. And we are social beings. If our social network is interrupted and disturbed or weak, then we are going to pay the price. And one of the ways of paying the price is through depression and a sense of inefficacy, failure, and et cetera. And then, of course, there are all the comorbid conditions that come along with depression, which we'll be talking about. And there's the quality of nutrition that people have in the United States. Certainly, if you I'll never forget going to a swimming pool in Florida a few years ago and looking around at the obesity. It's epidemic. Probably 70 to 80% of the U.S. population has insulin resistance, if not frank diabetes. So that's a big problem. And then we have the electromagnetic pollution. What is that doing? I don't think we know exactly, but probably in vulnerable individuals, that's a factor. And then, of course, we have endocrine disrupting hormone chemicals. We have thousands of new to nature chemicals that are known to cause disruption in the hormones. So that's playing a factor, a role. I know my grandmother, who's now deceased, may she rest in peace, when I tested her thyroid, she was in her 80s, I believe, and her thyroid hormone was completely normal. And what I've seen really is every cohort, people are getting ill at younger and younger ages. And now we see that with the insulin resistance diabetes is epidemic in children, right? And then, of course, we have air pollution, which is really better than it was in the 70s. And we have certainly mold in many college dormitories. Mold is a horrible problem that's causing lots of depression and failure, and et cetera. And then we have chronic infections, Lyme disease, that's really becoming more and more prevalent. At least we're recognizing it. So if the current model doesn't work, what do? Well, in psychiatry, there's a phenomenon that's been studied, and actually, if you read Robert Whitaker's book, Man in America, you'll see that there's a phenomenon where about every 50 years, roughly, there's a fad that comes along for the treatment of mental illness. This has been going on for 200 to 250 years. And in the beginning, it looks really great. And then after a while, it kind of fades and then not as effective. And then it's replaced by something else. So right now, what the treatments that are on the horizon, RTMS, transcranial magnetic stimulation. I don't think the data for that is so great. I looked into it very thoroughly, and there's a high relapse rate. It's expensive. They're now talking about theta burst RTMS, which may be more effective. We don't know yet. Then there's photobiomodulation, which I'm using. I'm impressed with it, but we're going to need obviously more studies. Psychedelics are also being used, ketamine, glycine agonists, glutamate receptor modulation, transcranial direct current stimulation. There are things that are on the horizon. But I think when it comes to the approach, we really need to get to the basics of physiology, psychology, sociology, and spirituality. And that's really what we're going to be focusing on. The comorbid conditions that I mentioned, I mean, there must be 15 or 20 comorbid conditions, comorbid with depression. In other words, they come when you get depression, you have a higher likelihood of having these conditions. So, for example, cancer, diabetes, osteoporosis, hormonal disorders, traumatic brain injury is a big one, obesity, I mentioned, autoimmune diseases, HIV, metabolic syndrome, coronary artery disease. There are many conditions that are comorbid. Asthma is another one. And then a big one is cognitive decline. We're going to talk about that. But interestingly, depression itself is a independent risk factor for coronary artery disease, heart disease. And the overall risk factor places it between passive smoking, which increases your risk by 1.25 factor. Depression is 1.64, and active smoking is 2.5. So it's very interesting that depression has that much of a effect on your risk for coronary artery disease, right? When it comes to neurodegenerative disease, this is pretty striking that individuals with mood disorders are at a moderate risk to a high risk. 30 to 50% of people with depression will develop mild cognitive impairment and dementia or Alzheimer's disease. And whether it's the beginning manifestation of that process, whether it is a kind of a trauma to the brain when someone's depressed that actually activates or contributes to those processes underlying dementia, we don't exactly know which direction it goes, or maybe both, but it's clearly a risk factor, a very significant risk factor. Why? Well, one reason is that depression itself is associated with a reduction in the number of neurons, reduced synapses, where the neurons connect to each other in the brain, and loss of branching in the neurons. So these are the dendrites, loss of dendrites. And this happens in the hippocampus and also in the frontal lobes. And it may very well likely happen also in the temporal lobes. PTSD, for example, which we will be talking about, changes the network connections and enlarges the amygdala, which is part of the emotional brain, part of the brain that detects risk, fear, sex, rage, The amygdala in PTSD actually becomes enlarged, and the connections between other nuclei in the brain change as a result of that trauma. So depression actually is reducing the normal neuronal structures and connectivity in the brain. So mood disorders need to be thought of as an early manifestation or contributors to the underlying processes, which later, frequently 30 to 50%, really, manifest as neurodegenerative disorders. Therefore, the mandate is to treat depression, prevent depression. Most important thing is preventive. Whatever you have to do, you have to prevent that and treat it very effectively. When it comes to anxiety disorders, there's much less research available about comorbidities, but we do know that PTSD, panic disorder, and agoraphobia are more likely, much more likely to be associated with comorbid physical disorders. So where are we now? We have limited recovery. We have comorbidities with illness. We have a quality of life problem because people are not really getting well. So they suffer and their families suffer and their employees who they work with and the business they work in suffer. And we also have a cost crisis because people are spending a lot of money, but not really getting well. So the next question really should be in your mind, how effective is functional medicine? And the answer is actually very effective. So I've written 3 books. My second book was a bestseller, and we actually had a 4-page spread in the Washington Post magazine, the health section. And so, of course, naturally, we had many, many phone calls. This was the antidepressant survival program, and it was basically functional medicine for depression. So we had so many phone calls, we could not possibly treat everybody that called. So we screened people to determine who was going to have the ability, the resources, the support to do a thorough and comprehensive functional medicine approach. And what happened was, I was a psychopharmacologist, and I was doing a lot of psychopharmacology in the 90s, particularly the early and mid 90s. I had shifted in the late 90s, and that's why I wrote the book. But what happened with this flood of patients was that I started treating everyone thoroughly with functional medicine, using the essentially the model that you're being taught. And what happened was I was struck by how much better people were going, and the fact that I did not need to use medications or change any medications for anybody, except for one person who I put on lithium to protect against suicidal risk. I thought I must be kidding myself because I was so astounded that osteoporosis was going away, diabetes was going away, people were losing weight. One patient who had MS, the lesions in her brain cleared up. It was pretty astounding. So I did a retrospective analysis of all the patients that I had treated over a given period of time with treatment-resistant depression. And at the beginning, their mean Beck depression inventory score was 34.2. And that's in the severe range, the low severe range. And by 4 months, they were down to 28.7. And that was just kind of when they were just getting onto their program for maybe 6 weeks or 8 weeks or 4 weeks. And then by 6 months, they were down to 15.4, more than a 50% reduction in their Beck depression inventory. 10 months, the mean Beck depression inventory score was 7.6. So I don't think you can beat that. Antidepressants don't come close. And so I'd have to say to you that the functional medicine model for mood disorders, for depression, these were unipolar depression and patients, is actually excellent. The evidence is excellent. So when it comes to this approach, I would say to you, the most important thing is that you have to be a detective. You have to figure out what's going on. You don't have to be a biochemist, but you do have to be a detective. You have to look for the causes, the root causes of dysfunction, and you have to treat the causes of dysfunction. And you have to do them simultaneously or nearly simultaneously, because this is a system in which, think of it like a system with a lot of different gears that are interlocking. you can't just treat one of these gears to get the system working. If you think of it as a watch, your grandfather's pocket watch, for example, this is an example I use actually often. Let's say you have a pocket watch from your grandfather, you want to use it, you want to wear it at a wedding, but it's not working. So you go to the jeweler and he opens it up and he looks in there. He says, well, there are 20 flywheels, 20 gears, let's say, and 6 of them look like they're broken. Well, you can change one, but the watch is not really going to work. And you can change 2, and it's not going to work, right? So if you change 3 or 4, the second hand might start to move a little bit, but it's not really going to be accurate. So you have to actually fix all the flywheels. If you fix, we don't have the knowledge yet to know where's that key point in those systems to pull on. There are certain things that are critical. Sleep is critical, right? Good quality relationships is critical, but if someone's sleep is disturbed, well, what's the source of that sleep disturbance? Well, the source could be inflammation. It could be melatonin. It could be adrenal. It could be thyroid. It could be zinc. It could be diet, right? Do you want to treat that? How do you want to treat it? It could be hormones like progesterone. How do you want to treat it? Well, you have to dig under the hood to see what the cause of that is. And then you can treat those causes. And then you probably don't have to say, here, take this sleeping pill. It might not be a bad idea to take a sleeping pill in the beginning, something maybe that's non-addictive, right? Just to get some sleep, because not getting good sleep is a major stressor, but you might need a sleep study to know what the source of the problem is. So no matter how you slice it, you got to dig deep. So you need to be a medical detective. And how do you do that? You go through all the functional medicine nodes, digestion, immune dysfunction, detoxification, oxidative stress, hormonal problems, genetics, methylation, structural problems, etc. And then you kind of try to make a timeline of how things developed. And that will give you clues, right? So that's kind of how we approach it. So we think in functional medicine about antecedents, factors that are genetic or acquired that precede or predispose a person to depression or anxiety, to an illness or some type of illness pattern. We think of triggers. These are factors that provoke the symptoms and the signs of illness. And then we think of mediators. These are the things that could be biochemical or psychosocial things that contribute to pathological changes and dysfunctional responses, right? So let's talk a little bit about antecedents, things that actually precede the depression and increase your vulnerability to the depression. And there are lots of antecedents. It could be traumatic brain injury, it could be family history, it could be parental toxin exposures, could be genetic vulnerabilities, like certain SNPs, could be, but it could also be bonding. And I'd like to spend a little time on bonding, because bonding, your primary relationship when you're young, is critical. So we know that early life stressors change the way our genes function. That's a fact. And we also know that healthy bonding is actually protective against anxiety. It's very clear. There are lots of studies that show that social support is essential for maintaining physical and mental health, without a doubt. And that's why we talked a little bit before about the breakdown of the social fabric in the community and the family as being a vulnerability factor. So the harmful consequences of poor social support and disruption of social support, and the protective effects of good social connectivity as well, is not without question. And it may even be more important, probably is more important as people age, and particularly the health status of older people. And then conversely, the lack of social support is definitely considered a risk factor in the development of depression. So one question that has to rise here is what's the long-term effect of early daycare treatment or early daycare placement of children, young children, a year old, 2 years, where they're in a facility with someone who may have the best heart, or maybe not, but let's say they do, but they're managing 6 kids or 7 kids or 8 kids, and what is the effect of that on our society as these children grow up, having those vulnerabilities? That's a big, big question. So how does this work, this bonding thing? So I was sitting actually maybe 15 years ago. I'll never forget this. I'm sitting in a strip mall on a bench. I'm just sitting there having my lunch, and there was a young mother who was carrying probably a 2 or 2.5 year old child who was screaming, 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 and she was carrying this child who was upset about who knows what. And she wasn't talking to him. She was just carrying him, and he's flailing, flailing. She crosses the parking lot, and she opens her minivan door and puts him into the car seat and straps him in, never saying a word, not a word of comfort. She's probably very embarrassed and stressed, and gets into the car, drives away. A few minutes later, another mother is walking with a young child, maybe a 3 or 4 year old, by the hand, walking with him by the hand, and he's kind of raising a little fuss and whining and kind of loudly, and she calmly says, "Yeah, I know, honey. Let's get you're hungry. Let's get you something to eat now. We're going to go home and have dinner, and let's go in here and get something to eat." And he kind of calmed down. So what's going on here? Well, the brain. If you think of the brain as 3 parts, the thinking brain, I think of it like an ice cream cone with 2 scoops. So yeah, the ice cream cone is the brain stem, controls respiration, heart rate, temperature, etc. The middle scoop is very simplistic, is the limbic brain, the emotional brain. And then the third scoop is your thinking brain, your prefrontal cortex, let's say, where you can plan and assess and judge, etc. Well, the thinking brain and the emotional brain are actually in a state where there's reciprocal inhibition. So the more active the thinking brain is, the less active the emotional brain is. And the more active the emotional brain is, the less active the thinking brain is. It's kind of like a seesaw, right? One goes up, the other goes down. Well, the young children don't have much of a prefrontal cortex. And so the mother, the primary caregiver, has to kind of use hers to take in the emotional state of that child, process it, and then feed back a logical, calming, mirroring response, which will calm down the child's emotional brain. And through that repetitive process, the limbic brain gets trained into and notices that regulation is possible. Limbic emotional regulation is possible. So if we look at that first mother whose child was flailing and she wasn't talking, she was not able herself to do anything to calm that child down. That child was learning actually the opposite, that there's no way of self-regulating. There's no regulation. There's no regulation. Even worse, she may have gotten home and smacked him on the behind, or even worse, right? So how does that child learn self-regulation, self-soothing? Well, it's very difficult. The other child, the second one, actually learns that there is a way of self-regulating. The limbic brain learns that experience of expecting regulation. And as the child's prefrontal cortex grows, then they can begin to do that themselves. Now, if you take the first child, the hypothalamic pituitary adrenal axis, the stress axis, is getting activated exceedingly, right? But the second child, actually, the hypothalamic pituitary adrenal stress axis is not really getting out of line, and so that actually works pretty well. So that gets entrained as well. So what's the consequence of this? So here are these 2 children. So let's take the first child who was really not being soothed, not being trained limbically. Not Mother was unable, probably because of her history, or maybe she has PMS or whatever it is. Whatever her factors are, she was unable to use her prefrontal cortex to calm the child. That child doesn't learn to self-regulate. That means when they go into school, if they're having, say, first grade, second grade, they can't self-regulate. If there are problems going on, say, with their peers, or they're having any kind of problems learning or something, they can't self-regulate. Now, they may appear like they have ADD because it can't focus and pay attention, because now their emotional brain is very active and their thinking brain isn't working so well because of that reciprocal seesaw kind of reciprocal inhibition, right, that I talked about. So now the child is identified as having ADD or anxiety disorder, put on stimulants, let's say, they're given stimulants, which we do not know really much about the long-term consequences of taking stimulants in the developing brain. Doesn't seem to be that important to researchers. Now the child moves along and they're having increased vulnerability to social difficulties and emotional difficulties, and they're not really functioning at their peak cognitively. And as they reach adolescence, and the stresses become greater, social stressors, the demands on them cognitively become greater, they might resort to other things to actually help them self-regulate or regulate, not self-regulate, like alcohol or inappropriate behaviors or video games or being on their phones all the time, whatever it is to get away from that emotional disruption. And these behaviors become an external way of regulating themselves, and they have adverse health consequences. So whether it's alcohol or eating too many sweets or being on video games, they're not going to perform as well in school, and they're going to have other so their careers, their earning capacity is going to be affected. And if they're overeating, they're going to become diabetic or pre-diabetic. And if they're using alcohol or substances, substance abuse problem, et cetera, et cetera. You can kind of see how these things snowball, and they're going to have, over the course of decades, they're going to increase their risk for disease and disability and social problems and disruption in their lives, and early death. So these adverse childhood experiences, this early bonding problem, is a big deal. And this, of course, is magnified through our society because of the breakdown of the family and putting children into daycare rather than having a good bonding experience with a primary caregiver because of the demands to make more money. And our expectations, our material expectations, are very high. We're trained to be consumers, and we think that we're going to get happiness through the material. We're going to get self-esteem through the material, et cetera. So this is the way the system is working, and we're seeing the problems developing as a result of this. So what are these risk factors? To summarize, adverse childhood experiences, trauma, neglect, abuse is the most strongest risk factor for anxiety and depression that we know of. There's a 32-year prospective longitudinal study that show that children exposed to adverse psychosocial experiences were at elevated risk of depression, high inflammation levels, and a clustering of metabolic risk factors. So this is not theoretical. This is very real. Now let's talk a little bit about triggering events. Let's talk in that regard. Let's use PTSD as an example. So post-traumatic stress disorder, kind of shifting gears here from depression to post-traumatic stress disorder, as one example of an anxiety disorder that is actually really a whole body disorder. It masquerades as a psychiatric disorder, but it's really a whole body disorder that is a result of a repetitive and unrelenting assault on the mind, the body, the spirit, the brain. and it leads to very, very serious and consequential damage for the person, including the duration of their life expectancy, right? So what is PTSD? So I have a little mnemonic: trauma, T. T is the traumatic event. R is re-exposure to that event, and it could be psychological. You could be having recurrent thinking about it, or re-exposure, actual re-exposure. A is avoidance of anything that reminds one of the event. U is inability to function. M is last a month or longer, and A is excessive arousal, and in response to these triggering thoughts or images or exposures. So it affects mood, cognition, arousal, and people can feel very flat. They can look depressed, they have intrusive thoughts, and it's quite debilitating for people. And one of the central vulnerabilities for getting PTSD has to do with genetics. There's good evidence now that the hypothalamic pituitary adrenal axis is a central feature in the vulnerability to PTSD. Early trauma is a central vulnerability, poor relational connectivity, certain schemas about life, ways of thinking about life, and even prenatal stress, transgenerational stress may be a vulnerability factor. For example, people whose parents survived the Holocaust, you know. So you have those vulnerability factors. Then you have exposure to a trauma, and then what happens is you end up, because your hypothalamic pituitary adrenal axis is incapable of responding fully to make adequate levels, this is part of the theory, adequate levels of cortisol. High cortisol helps you forget an experience. Lower cortisol makes it harder to forget. When you have high cortisol, the hippocampus doesn't register memory as well. So it's actually advantageous to have high cortisol. And high cortisol also keeps the inflammatory response down. And what happens is, now once you're in the PTSD and you're having these recurrences, you're in a state of sympathetic dominance. The autonomic nervous system is overactive. The locus coeruleus in the brain, which controls the, it's a small pea-sized nucleus of cells in the brain that is actually blue. If you look at it as a blue tinge from all the noradrenaline cells in there that control the adrenaline in the brain, noradrenaline in the brain. And so you have an overactivation and imbalance of the autonomic nervous system. Now, then as a result of these recurrences, you have changes in network functioning and structure and the connectivity. So the kind of the highways between different areas in the brain, like the amygdala, the prefrontal cortex, the temporal lobe, the normal patterns of communication, or even the size of these communication highways changes in PTSD. And these are associated with increased rage, trouble with concentration because of the functional disconnection between the frontal lobes and the emotional brain, like the amygdala. Executive function is impaired. And then we have also difficulty, as I mentioned, encoding memory. Serotonin levels are often reduced. And then you have changes, of course, downstream changes in the immune system because of all this stress and the GI microbiome. And then you have changes in cytokine production, and the NMDA receptors are overstimulated by glutamate and kynurenine pathways being stimulated. And then because you're now in a more depressive, obsessive loop, in part related to the noradrenergic stimulation, the low ability to control inflammation, and low serotonin function related to some of these changes, you're going to have more rumination, intrusive thoughts, and this goes on and on and on, and you cannot escape it. You end up feeling helpless, and you end up feeling depressed, and this feeds back into a cycle between all of these areas. And this is kind of a loop that the person is going through. and it's quite stressful. So what's the effect of this on the body? Well, a study was done where they looked at a large number. I'm not sure what the number was, but this was a study that shows they looked at veterans, people in the armed services, pre and post deployment, and they found that post deployment, 71% of the genes showed significant changes in gene expression in people who had PTSD. So 71% of the genetic function of these people who had PTSD before and after deployment had changes in the genes. And there were two modules that seemed to come out as most important. And one was related to BDNF, brain-derived neurotrophic factor. Another one were the SLC6A4 gene, which encodes for the serotonin reuptake pump and the STAT5A and STAT5B, et cetera. So the main point here really is how massive an effect the PTSD has on gene expression. And then there are studies on the comorbidities that come along with PTSD, and there were 64 studies, and the comorbidities are just astounding, just astounding. So there's a shortened telomere length. And so there were 6 studies, all of them showed a shortened telomere length, which is associated with aging, right? Gastrointestinal ulcers, 4 out of 4 studies show increased risk. Hypertension, 7 out of 12 studies showed increased risk. Inflammation, 16 studies showed increased levels of interleukin-6, interleukin-1 beta was changed, CRP, TNF-alpha changed. Oxidative stress, 5 studies correlated with PTSD. Diabetes mellitus, diabetes type 2, 3 out of 4 studies showed comorbidity risk with PTSD. And then earlier mortality, 7 out of 10 studies showed a 29% increased risk of mortality, the earlier mortality. So that's why I say this is a whole body disorder, really masquerading as a psychological illness. It should not really be listed as a psychological illness. So we have autoimmune disease, mast cell disorders, pulmonary disease, depression, substance abuse, of course, right? Traumatic brain injury, suicide risk, and of course, lots of bodily complaints and disruption in the family. And this is a massive problem. PTSD is a massive problem. 5 of 6 studies, all from the United States, indicated that veterans diagnosed with either PTSD or major depressive disorder were at a significantly greater risk of developing dementia than healthy controls. There's a retrospective study done. It collected data between 1999 and 2014, 849 people, dementia patients with dementia. And this is very interesting because they looked for PTSD in the history, and they found that 38 patients, 4.5%, had a history of PTSD. But when they segregated it out, the biggest correlation in terms of dementia and PTSD is frontotemporal dementia. 14% of these dementia patients had frontotemporal dementia. The semantic variant of frontotemporal dementia, which means there's a difficulty with language and speech, not behavior. So this is not surprising because frontotemporal dementia, frontal lobes and temporal lobes. The temporal lobes are where a lot of the emotional structures in the brain are, and the frontal lobes is the executive function. When we look at PTSD, those are the areas that are affected by the trauma. And so that, as I said earlier, that is almost like engraving a trauma into the brain, causing dysfunction in the neurons in these parts of the brain, which increases the risk for dementia, FTD, and other dementias, but mainly FTD. And you start to think of it this way, you realize that when someone comes in with PTSD, you actually really have to This is not a psychological problem. This is a serious issue, and you're kind of seeing an early manifestation what later could become a neurodegenerative disorder. It needs aggressive treatment, and it needs whole body treatment, whole mind treatment, spiritual treatment, you name it. You got to really address this. So this is a major issue here. Veterans with PTSD were at nearly twofold higher risk compared to those without for increased dementia risk. So it's a big issue, okay? Bottom line is PTSD is common, devastating, and occasionally fatal, right, because of suicide, a result of exposure to trauma. And there are some treatments that exist that are effective, but treatment options are limited. So we need new approaches for this, and functional medicine is part of that. Remember, PTSD is not a psychological illness. It's a whole person illness masquerading as a psychological illness. Let's talk a little bit more now about the hypothalamic pituitary adrenal axis. The hypothalamic pituitary adrenal axis has several levels, and classically we talk about it as starting in the prefrontal cortex here, and then going down to the hypothalamus, and from there to the pituitary, and from there to the adrenal gland sitting over your kidneys. So when there's a perceived stress, a threat, it could be real or could just be perceived, but it's a stress nevertheless. We have that seesaw where the prefrontal cortex shuts down to some degree, and the emotional brain gets overactivated. The amygdala and the locus coeruleus get overactivated, and this is the core stress response system. And then what we have is the hypothalamus, the paraventricular nucleus is stimulated, and that releases corticotropin releasing hormone, or also called corticotropin releasing factor. And the anterior pituitary gland is stimulated and puts out adrenocorticotropic hormone, ACTH, which stimulates the adrenal gland to put out adrenaline, which stimulates the body in terms of an activation, and also cortisol. And the cortisol feeds back at the higher levels to inhibit further production, right? But there's another layer to this classic system, and that is how effective is that cortisol signal? How effectively is that signal translated into the genes? Meaning, some people have genetic variabilities in the NR3C1, FKBP5, CRH receptor 1 and 2 genes that actually, even if the whole system is working right, when that cortisol gets to the nucleus, the envelope around the nucleus, it can't be translated into or transduced. The signal is not transduced into the nucleus, so that all the genes that are involved, the downstream effects of cortisol, are muted. So under stress, there's a muted ability of the genetics to adapt to the stress. And this is a vulnerability factor for PTSD, and also immune dysfunction, and also for suicide, and also for depression. And this is well documented in the literature. So what we have really is, when we talk about depression, we have two types, in a broad sense, two types of depression. One could be a high cortisol depression. And in that case, you're going to see people, if you do a salivary cortisol, urinary cortisol testing, you're going to see high levels of cortisol, which these people are agitated and anxious, and they want to jump out of the skin, and they're really at high risk for suicide. And then you have the low cortisol depression, which you might think of more as someone who's kind of chronic fatigue, low energy, they don't want to get out of bed, they're sensitive to criticism and rejection, and it's a different pattern. But both would fall into the category of depression, unipolar depression, but they're very different, and the treatment is very different. So there are clear differences, but there's an overlap between the two. You might see someone with high cortisol one time of the day and low cortisol another time of the day, et cetera. But this is very important when you're treating depression, is to identify the cortisol pattern using, whether you use salivary cortisol testing or urinary cortisol testing, and if necessary, looking at different parts of this pathway going from the prefrontal cortex to the hypothalamus to the pituitary to the adrenal and the genetics. You're going to test as many of those as possible to figure out where in this chain of events is the problem. And that includes doing some genetic testing, maybe doing some brain imaging when necessary, or ACTH stimulation testing. So here's an example I'll give you of a middle-aged guy who actually went through a divorce. And when we checked his ACTH, that's the pituitary signal to the adrenals, the ACTH was 59.4, which is at the very high limit of normal. And he had many variants in this nuclear receptor 3C1 gene. So that basically showed that he was unable to convert the cortisol when he's under stress into an effective signal that would help his body and his mind adapt to the stress. So under low stress conditions, he might be fine, but on high stress conditions, he couldn't adapt because of this. And so this was with him his whole life. And probably when he was a young child, I would imagine, I don't know, the cortisol levels, if they were measured, might have been high. He might have looked like an anxious child because he was having a lot of high cortisol. But with time, the adrenal glands can only put out so much, and someone like this is likely to show up as low cortisol because the adrenals is kind of an adrenal failure or adrenal insufficiency. And giving him hydrocortisone was actually quite remarkable. Within an hour, he reported feeling better. So that was pretty striking. Now, this is someone who might need hydrocortisone in physiologic doses, not high doses, not, but he might need this over the course of his life intermittently or chronically, which would require monitoring, et cetera. But it gets to the source of one of his vulnerabilities. The next thing I want to talk about is really at the center of the functional medicine matrix, which is beliefs. And I want to talk about learned helplessness. Learned helplessness is the best model for depression. And learned helplessness is a model developed by Martin Seligman. And basically what he did is he put a dog in a box that had two compartments. And the dog could, really shuttle back and forth between the two compartments at will. And so when it was in compartment A, they gave the dog an electric shock, and then the dog could jump over the fence into compartment B and escape the shock, and could do this all day long. The dog is fine. And when they closed the escape hatch, the dog couldn't escape. Give him a shock, he'd start to get agitated, which was probably an anxiety state. And then it would just fall into what we'd have to call as a helpless, depressed state, where you'd shock it, but it wouldn't even move. Then what they did is they opened the escape hatch, and the dog could see that it was open, and they'd give the dog a shock. And what would happen? It wouldn't jump over the fence. It would have to be carried over the fence 100 to 150 times. Shock, carry over the fence 100, 150 times. And then it would reestablish its ability to take action in response to the stimulus. So in human beings who come to you with depression, you kind of want to use this model to kind of shock. What's preventing them from jumping over the fence? And what is on the other side of the fence besides relief from the shock? What's on the other side of the fence could be the desire for power or control. It could be, a lack of control that they're experiencing. It could be the need to be loved or to be loving. It could be self-esteem. Different people and researchers have talked about it in different ways. But if you think of it with a patient with depression, you want to use this model and figure out, well, where's the shock? What's blocking them? Now, what could be blocking them could be their thinking, or it could be a real problem. In other words, they can actually be in a helpless situation with a real shock, and then you need to strategize how they're going to get out of that. But that is central from the psychosocial perspective to figure out with your patients. You must identify the sources of the trauma, the defeat, it could be social defeat, of the helplessness, but you must use that, that model. Now, you could ask the patient, well, if you had energy, a lot of patients with depression have no energy. You could say, well, if you had energy, would your depression be gone? And some patients, not a insignificant number, will tell you, well, if I had energy, I wouldn't be depressed. And then you kind of know it's actually an energy problem. It could be hormonal, could be inflammation, could be mitochondrial, etc. But you kind of know that it has to do with that area of the matrix, right? So very important to identify that. Okay, so what's trapping your patient? What's the shock? Is it reality based? Is it based in cognitions and faulty ways of thinking, faulty assumptions about life? Is it energy based? These are the questions, fundamental questions that you have to answer when you are looking at somebody who has depression. So we're actually a little bit above animals, right? We have a larger prefrontal cortex. And so I think that we actually can go beyond the learned helplessness model. But when a person comes to you with depression, they're kind of in that animal state where their limbic brain is running the show and their thinking brain is offline. And in fact, if you do cognitive therapy, if they're in a moderate to severe depression, they may tell you that it makes sense to them, but the minute they walk out of the therapist's office, all the thinking in the world doesn't matter. They feel the same. It just doesn't stick. In that case, you're using more of the behavioral part of cognitive behavioral therapy. So that could be assigning tasks, breaking down tasks into small bite-sized pieces so that they can actually start to take little steps in the way of activation. Motivation doesn't come first, action comes first, then motivation comes second, right? So that's very important to teach your patients. But let's think about prevention of depression. Somebody's had depression. How do you prevent future episodes from a psychosocial perspective? Well, when we're talking about prevention, we can actually go beyond, in humans anyway, we can go beyond the learned helplessness model. And it has to do with a few things that are more, a little bit more in the spiritual realm. Okay, now, metaphysical, spiritual realm, religious realm, whatever you want to call it. So in life, if you really, really look at it, there are things you can control, things you can influence, and there are things that you cannot control. If you really, really look at it, you will see that there are very few things that you actually can control. What you can control is your attitude, right? And sometimes you can control some things or you can influence things, but there are many things that you can't control. But we are built in a culture that, and it's maybe human nature, but maybe not. Maybe it's just our culture where we love control. We all want control. We want the world to function according to our rules, right? But it's unrealistic. So if you start to recognize that that's not how the world works, and you start to accept, and it takes work, but you develop the understanding that you need to kind of learn how to go with the flow, do what you can, go with the flow, and accept the lack of control you have, then you're less vulnerable. You're not, when it comes to a situation where you don't have control, you can start to say, well, that's not a lot. You don't lose self-esteem over that. It's just the nature of how the world is. It doesn't mean you don't do things, you don't work on your attitude, and don't take action where you need to or can. But we really can use this model to have more resilience against depression. So I want to dig deeper a little bit into this. And there are a few ideas I want to get across. One is, and now I'm moving into the spiritual realm, okay? There are things that we don't know. In fact, we don't know most things. We like to think we know a lot, but we don't. One example. Let's go back 150 years. Did anyone know about the electromagnetic spectrum? Say 400 years, go back 400 years. We didn't know about the electromagnetic spectrum, but was it affecting life? Did we know about neutrinos passing through our body? No. But did they exist? Yes, they did. 95%, according to physicists, 95% of the universe is made up of dark matter and dark energy. What do we know about it? Nothing. Well, that's pretty astounding. Well, look at the medical field. Medical recommendations change all the time, right? John Ioannidis tells us that most of our research studies are actually not reproducible. But we persist in the idea that we really know, but we don't. We don't really know that much. And that's the reality, if you really want to look at it very carefully. We don't know. Therefore, you have to accept the possibility that a metaphysical, meaning beyond the physical, existence exists. Now, you might say, no, it doesn't. I'm an atheist. Or you might say, no, I believe in God. I believe in a creator. I believe in a controlling higher intelligence, whatever you want to call it. Both the atheist and the believer are believers. The atheist is believing something they cannot prove. The only one who is logical is the agnostic. The agnostic says, I don't know. And that's the truth. We don't know, right? So there's actually a lot of evidence, however, that there is a metaphysical world. And if you read about quantum physics and quantum entanglement, where electrons that have been, or photons that have spent a little time together can be separated by distances that are huge, I mean miles and miles, and measuring the spin of one photon instantaneously, faster than the speed of light, changes the spin of the second photon in a complementary manner. It's been reproduced many, many times. How is that possible? There's something else going on, and they call it quantum entanglement. Quantum processes actually are functioning in our own bodies. There's a lot of evidence for that now that's accumulating. Certainly it's shown in plants. That means that when a molecule signal goes in a plant, for example, that electron is only in potential, and there are 5 pathways where it can go, and it doesn't really pick a path, and suddenly it picks a pathway and it's concretized and materialized, okay? So there's a metaphysical realm. There's a lot of studies on the metaphysical, but if you really have an open mind, you say, well, there's something here. What is it? We don't exactly understand it. People call it the zone of reciprocity, where there's a kind of a interactive layer with the metaphysical realm and the 0-point field. Some people talk about a soul. Some people talk about past life. There's just a lot of stuff here, but there's something more going on. Karma, there's all these ideas. This is a real thing because there's a lot of data, but it doesn't get accepted because we don't really know where to put it in our framework, in our materialistic framework. But we do that at our detriment because there is something greater going on. The United States Army, in their manual, tells soldiers who are tracking another person not to stare at the back of their head, because research has shown that the people will turn around. How is that possible? It's possible because there's something else going on. So the metaphysical, well, we don't understand it, gives the possibility of meaning for life, right? And the reason we don't understand it, we don't accept it, is because we're actually all brainwashed, right? We're brainwashed in this materialistic perspective. But the reality is that how we experience the world is affected by the information we assimilate. So if you're taking in video games and Law and Order shows and hostilities or whatever it is, this is garbage in, garbage out. So now you have to assimilate, just like information is food, the people you interact with, the things you read, the media you expose yourself to, this is also assimilation, and this will actually have a profound effect on your mental health and your physical health as well. So you must carefully control and assess, curate infinite informational and social input and what you read, etc. And you should determine what kind of output you want, what kind of mind state do you want. You want to be happy, you want to be joyful, you want to be whatever, what do you want to be? You want to be angry, you want to be a social warrior, what do you want to be? Control your input, because each and every one of us is brainwashed by the input, and our society actually is, brainwashing us constantly. That's just the nature of the way we are. So you have to control that. If you do that, if you control the focus of your awareness, you actually can control your consciousness and you can control your experience. Now, what's the ideal from a prevention of depression and anxiety? What's the ideal focus? The ideal focus is actually a focus on belief in a higher power, that life has purpose and meaning and direction. And the other thing is that you need to cultivate the skill of faith. Faith is a skill. Most people are not born with faith. Faith is the idea that you can trust, even when things are not going your way, that there's a benefit. So, for example, a young child who has faith in their parent knows that the parent cares about them, the parent can protect them, and the parent may choose to do things that they might not like, but that the parent has their best interest. So how do you develop this faith, in a creator, a God, a higher power, an intelligence of the universe, whatever you want to call it? Well, that's a skill. That is something that you have to actually develop. It's not a natural skill. But the research shows that people who are in faith-based communities actually have decreased incidence of depression by 29%. All-cause mortality is reduced by 25 to 35% over 10 to 15 years. So they get, on average, 7 years extra of life. Suicide rate is reduced by 84%. The divorce rate is reduced by 30 to 50%. Substance abuse goes down, and the happiness index goes up. So you really want to be in a life-affirming community, and you want to work on developing your faith, right? And that's a skill. Now you could say, well, that's nonsense. We can't know, and that's right, we can't know. But life, resilience, the quality of your life is better with that perspective. And since you're really going to be brainwashed one way or another by what you're around, you might as well pick the way of viewing the world that's going to work best for you and the people around you. And so I would say in closing that while learned helplessness is a great model for people in depression, the development of a spiritual perspective and a faith-based affiliation, developing faith skills is actually your best protection against depression, illness, mental illness. Well, I shouldn't say all mental illness, but anxiety disorders. It's not an absolute protection for sure, but it actually does work. But it's a skill, and we don't think of it that way, but it is a skill that can be very helpful and has been shown in many studies to be very helpful. So I hope that's been helpful to you. Please feel free to share this recording.